Akash. I wonder if you could just introduce yourself and perhaps explain a little bit about your unit, what you do here.
So I work as a consultant here in the PICU of King's, and King's is, as you know, is a very large liver transplant center in Europe. So a lot of our patients are liver patients. They also develop a lot of sepsis. So patients with sepsis, patients with liver failure, and patients with traumatic brain injuries, what we deal here with at King's.
And so what's your particular areas of interest, Akash? You've done a lot of work with hemodynamics over the last 10 years. What's your particular focus and what's your interest in?
I think dealing with the kind of patients I deal with, for example, patients who've got coagulopathy, who've got low platelets, I think it's virtually almost impossible to get invasive hemodynamic monitoring done. So I think having a non-invasive device really helps. And ever since I got introduced to Uscom, which is your cardiac output monitoring by ultrasound, I think it's really changed the way I actually manage my patients, because previously it used to be fluids for everyone, but now I think all of us think about it and say, does my patient require fluids? And if that question is answered, has my patient responded to fluids? I think both these questions are very, very pertinent to the patient management, I think, and Uscom gives you a very good overview of the fluids, of the vasopressors, and especially when you've got children who've got raised intra-abdominal pressure, for example, in liver transplant patients, this device is fantastic.
The last 5 or so years, there's been a real shift in focus towards hemodynamics, but there's still generally sort of widespread uncertainty about how we manage even the basics of fluid inotropes and vasoactives. So this has been your focus, hasn't it? Particularly sort of moving towards concepts of oxygen delivery.
So if you read a paper which has just been published in Frontiers of Pediatrics last month, we talk about how oxygen delivery, oxygen consumption, its correlation with the usual dynamics which we use, for example, the lactate, your CVP, all that stuff, how that changes the way we manage patients. And I think oxygen delivery ultimately is the key, because that's what we look at: oxygen delivery, how much oxygen is consumed at the tissue level. And I think Uscom again gives you the answer with that.
So from your point of view, it's an integrated tool in clinical practice?
I think when you look at this machine, besides being an integrated tool, I think the thing which I look at when I buy any tool is it easy to use? And I think this is a tool which can be used by the nursing staff, by the junior doctors, by us, and it requires training. I would say not more than half a day of training, and you need to have 20 readings to go. That's fun, easy to use, very user-friendly, and easy to interpret. The readings are very easy to interpret as long as you understand the hemodynamics, and I think Uscom gives you your cardiac index, it gives you your SVRI, it gives you whether you're well-filled, overfilled, underfilled, and also tells you about oxygen delivery. So I think, yes, it is an integrated tool.
So at a more fundamental level, do you use non-invasive Uscom hemodynamics as a routine on your patients who come through your ICU?
I think that's what we have been able to establish over the last few years. We have made it as a standard of practice. So, for example, when the junior doctors come to us in September and March every year, as a part of induction, we make sure that they're introduced to Uscom. One of us teaches them on Uscom, and they are ready to go in a week's time, because they give us 20 readings, which we then interpret and make sure those readings are right. So every junior doctor who works on the ICU of King's is competent to do Uscom. So yes, it is a standard of care.
And you mark down the results with other physiologic obs?
Absolutely. So it's not taken in isolation. We look at our clinical variables, we look at our biochemical variables, including lactate and SCVO2, and the Uscom findings, and then come to a conclusion. What state is my child? Is it normodynamic? Is it hyperdynamic? Is it hypodynamic? So I think it has to be used in conjunction with your with your clinical case. Yes.
Your specialty also is renal failure, isn't it?
Yes.
And management of those patients.
I think if you look at the recent paper called the AWARE study, which we published in New England Journal of Medicine, very clearly shows that almost a quarter of our patients who get admitted to intensive care develop acute kidney injury and the associated morbidity and the mortality with it. And if you're able to predict your AKI right on day one and say, this is the group of my patients who's ultimately going to develop acute kidney injury, it will help us monitor our nephrotoxic drugs, the way we give fluids. So what we did was we looked at our initial presenting hemodynamics of patients with septic shock and said, what can we pick up at presentation which could predict AKI on day 3? And again, by using Uscom, we were able to demonstrate that any patient who's got a low SVRI on presentation, low diastolic pressure, are the patients who are more prone to develop AKI on day 3. And we were able to then rationalize our nephrotoxic drugs and the fluids using Uscom.
So, in summary, Akash, you feel confident that it's changed your practice and changed outcomes for your patients?
I think if you, not only me, if you ask any user of Uscom on the unit, it's become like when somebody calls me in the middle of the night and says, I have got a child with a tachycardia, with this, with that, I automatically now get a phone call saying, in addition to this, the Uscom is showing this. So I think all of us as a team have started using Uscom as a part of the care, and I think it has definitely changed the way we manage patients. Absolutely.
Listen, Akash, great to spend time with you, and thanks very much.
Thank you.